So histamine 1 blocker, and then we will go to the second generation histamine blocker. So this is the first generation, you can see over here, this is the first generation, then second generation, then we will go to the guanfacine. Okay, so first of all, reversible inhibitors of H1 histamine receptors, diphenhydramine, dimenhydrinate, chlorpheniramine, and doxylamine. So any drugs with "-mine" at the end. Okay, only one thing is that dimenhydrinate, even there you can see N. Okay, right? So dimenhydrinate names usually contains N or in or N or 8. Okay, so what are the use is allergy, motion sickness, sleep aid, and effects. Side effects are sedation, antimuscarinics, and anti-alpha adrenergic. Okay, so the side here I have written from your word that the side effect of antihistamines are largely due to blockade of other pathways. For example, it can block cholinergic pathway, leading to anticholinergic symptoms. For example, blurry vision, exacerbation of glaucoma, urine retention, delirium, and constipation. Okay, so this urine retention can be useful in some sort of a kind of incontinence known as urge incontinence, where the bladder is hyperactive. Okay, so urine retention can be there. Now also there is alpha adrenergic, so postural dizziness or false, serotonergic, appetite stimulation and weight gain, and a newer generation loratadine or cetirizine. Now, these loratadine and cetirizine do not have the same degree of anticholinergic or anti-serotonergic or anti-alpha properties. Okay. Moreover, second generation are less lipophilic, do not readily cross the blood-brain barrier, and are usually non-sedating. So remember that whenever, if the question tells you that there is a driver or there is a person who don't want to, get dizzy or sleep, then you should use second generation antihistaminics. Okay, for allergy. So coming back to second generation antihistaminics, we have loratadine. Okay, so DIN is for the second generation. So loratadine, fexofenadine, and desloratadine or cetirizine. Okay, cetirizine is unique type of very commonly used second generation antihistaminics. Use is in the allergy, and side effects are far less sedating than first generation because of decreased entry into the CNS. So it cannot enter, it is less lipophilic, so it cannot enter the CNS, right? Now talking about guanfacine, these are expectorant, thins respiratory secretion, does not suppress cough reflex. Remember that. It stimulates the flow of respiratory secretion rather than increase. So it will simply increase the flow by reducing the viscosity. Okay, remember that. Expectorant does not cause the increase in secretion, rather it just thins the respiratory secretion whatever we have, right? N-acetylcysteine, you can see N-acetylcysteine is a mucolytic. It liquefies mucus in chronic bronchopulmonary disease, for example COPD or cystic fibrosis, by disrupting disulfide bonds. Also used as an antidote for acetaminophen overdose. Okay, remember that. As you remember, in acetaminophen overdose we use N-acetylcysteine, so it can so this is one use, and the other use is during the COPD or cystic fibrosis. Apart from N-acetylcysteine, you should also give anti-pseudomonal drug. Okay, now talking about dextromethorphan. Dextromethorphan is an antitussive. Okay, antagonizes NMDA glutamate receptors. Okay, so synthetic codeine analog has mild opioid effect when used in excess. Naloxone can be given for overdose, mild abuse potential, and may cause serotonergic syndrome if combined with other serotonergic agents. So this is one of those drugs which can also cause serotonin syndrome if given with other serotonergic agents. Now talking about pseudoephedrine and phenylephrine. These are alpha adrenergic agonists, so that's why it can reduce hyperemia, edema. Also used as nasal decongestant, and it can also open the obstructed eustachian tubes. Okay, side effect is hypertension, rebound congestion if used more than 4 to 6 days. So obviously it is alpha adrenergic agonist, so it can cause hypertension, and rebound congestion if used more than 4 to 6 days. So basically you use maximum till less than 1 week. Okay, can also cause CNS stimulation, anxiety, obviously, because pseudoephedrine is a releaser. Okay, it is type of amphetamine. Now talking about pulmonary hypertension drugs. So what are the pulmonary hypertension drug? Endothelin receptor antagonist. Okay, so endothelin receptor antagonist, for example, what are those drugs? Bucentran, right? Yes. So bosentan, it will competitively antagonize the endothelin 1 receptor, decreasing the pulmonary vascular resistance. One thing that you need to imagine is that there is a fat boss with hepatic failure. Okay, so that is how I remember the adverse effect of bosentan, which is hepatotoxic. Okay, now talking about phosphodiesterase 5 inhibitors, inhibit phosphodiesterase 5, leading to increased CGMP. Okay, prolonged vasodilatory effect of nitric oxide, also used to treat erectile dysfunction, contraindicated when when taking nitroglycerin or other nitrate drugs due to risk of severe hypertension. Example is sildenafil. Okay. Next is prostacyclin analogs, which is PGI2 prostacyclin, with direct vasodilatory effects on the pulmonary and systemic arterial vascular beds, also inhibits the platelet aggregation. Side effect is flushing, jaw pain, and examples are ipoprostenol and iloprost. Okay, next page. So next is asthma drugs. Bronchoconstriction is mediated by inflammatory process and parasympathetic tone. Therapy is directed at these two pathways. Okay, so you can use beta 2 agonist, that is albuterol. Albuterol relaxes bronchial smooth muscle. It is short acting beta 2 agonist for acute exacerbation, but can cause tremor and arrhythmia. Salmeterol and formoterol are long acting variants. Okay, used for the prophylaxis, but it can also cause, as albuterol, tremor and arrhythmia. Okay, now talking about inhaled corticosteroid, fluticasone and budesonide inhibits the synthesis of virtually all cytokines, inactivate NFKB, the transcription factor activator that induces production of TNF alpha and other inflammatory agents. First line therapy for chronic asthma. Use a spacer or rinse mouth after use to prevent oral thrush. Now, muscarinic antagonists like tiotropium and ipratropium competitively block muscarinic receptor, preventing bronchoconstriction, also used for COPD. Tiotropium is a long-acting. How to remember that? Tio. That's why I have written like that. Tio is for long-acting, okay? For long time. Also, TI for time and TI for tiotropium. Okay, and anti-leukotrienes, for example, montelukast, jafirlukast, blocks the leukotriene receptor cis LT1, especially good for the aspirin induced asthma. Okay, and exercise induced asthma. So if it is exercise induced or aspirin induced, you should think of using montelukast and zafirlukast. G-lutein is a 5-lipoxygenase pathway inhibitor, blocks the conversion of arachidonic acid to leukotriene, and it is hepatotoxic. G-lutein is hepatotoxic. Just imagine the Godzilla with hepatic sign on its belly. Okay, now talking about anti-IgE monoclonal therapy. This is omalizumab, binds mostly unbound serum IgE and blocks binding to the Fc region of ERI. Okay, so used in allergic asthma with increased IgE level, resistant to inhaled steroid and long-acting beta 2. So suppose if the asthma is uncontrolled by inhaled steroids and long-acting beta 2 agonist, you should think of omalizumab. Okay, so in case of allergic asthma. Now talking about methylxanthine, these are theophylline, likely causes bronchodilation by inhibiting phosphodiesterase, which leads to the increase in CAMP level due to decreased CAMP hydrolysis. Obviously, limited use due to narrow therapeutic index. Remember, this is also one of those type of drugs with a very narrow therapeutic index, just like warfarin and lithium. Okay, so it can cause cardiotoxicity, neurotoxicity, metabolized by cytochrome P450, blocks the action of adenosine. So remember, the patient who is on adenosine should avoid taking tea or coffee because they also contain little amount of theophylline, right? Now chromones. Chromones are chromoline, prevents mast cell degranulation, prevents acute asthma symptoms, rarely used nowadays. So here also you can see in this picture that exposure to antigen dust pollen, so at this level you can do avoid. Okay, antigen and IgE on mast cells, you can use omalizumab, which will bind with the, which will block the binding of immunoglobulin to the mast cells. Okay, by binding it by itself. Okay, so omalizumab will bind with IgE and not let the binding of IgE to the mast cells, and no degranulation. Now other things that you can think of is steroid hormones. Okay, so this can also lead to decrease and degranulation. Now after the mediator has been released, you can use beta agonist or theophylline or muscarinic antagonist. Early response post bronchoconstriction. Steroid and anti-leukotrienes can be used for late response inflammation and symptoms. So symptoms and bronchial hyperactivity. So you can basically see the point where all the drugs can act. Okay, now talking about methacholine. Methacholine is non-selective muscarinic agonist used in bronchial challenge test to help diagnose asthma. MgSO4 inhibits calcium influx into the airway smooth muscle, leading to bronchodilation. So basically magnesium sulfate will inhibit the calcium influx into the airway smooth muscle, so there will be no bronchoconstriction, leading to bronchodilation. So that is how magnesium sulfate works. There is one more drug, reslizumab. Reslizumab is a monoclonal antibody directed against interleukin 5. Okay, reslizumab used in eosinophilic asthma. Phosphodiesterase 4 inhibitor is roflumilast, blocks degradation of CAMP, used in COPD. Okay, here I have written something about acute exacerbation of COPD. So what you will do for the acute exacerbation, you give O2, okay, and nebulized albuterol plus minus with or without apratropium. This is called combivent. IV or oral corticosteroid, prednisolone 60 mg daily, methylprednisolone 80 mg IV per 8 hours. Okay, and antibiotics is, for the severe and hospitalized patient, usually fluoroquinolones. Why? Because it can also act against pseudomonas, and amoxiclav. Okay, next I have written is that pallavizumab is a monoclonal antibodies against F protein of fusion protein of respiratory syncytial virus. Okay, causes respiratory epithelium to fuse. So basically you will put an antibody against this fusion protein. Here I have written a special COPD drug is roflumilast. I have already talked about that, right? It is a roflumilast is a per oral drug used in mechanism of action is similar to the phosphodiesterase, other phosphodiesterase inhibitor. It also decreases inflammation and may relax airway smooth muscles. Okay. In case of asthma acute exacerbation, you can use O2, nebulized albuterol, IV or oral corticosteroid, prednisolone 60 mg daily, and methylprednisolone 80 mg IV per 8 hour. Okay. Rarely used drugs are ipratropium and IV magnesium sulfate. Anything else? Okay, so here I have written clubbing. What are the causes of clubbing? So last thing that I want to add in recipe unit is clubbing. So in lung disease, you can see clubbing in lung cancer, TB, cystic fibrosis, bronchiectasis, pulmonary hypertension, emphysema, and COPD. In heart disease, you can see in the TOF, bacterial endocarditis. Inflammatory bowel disease, you can see in Crohn's and ulcerative colitis, and also in the hyperthyroidism. Normally, the type of respiration is like this, and in Cosmol, it is deep breathing, and in Biot's respiration is somewhat irregular breathing, which is usually seen in opioid use, irregular frequency, and irregular tides with apneic spells. Okay, Chinese strokes, I have already talked about Chinese strokes. And I have included some list of disease where you can see livedo reticularis. So it is amantadine, okay, also polyarthritis nodosa, atheroembolic disease, SLE, antiphospholipid syndrome. Okay, SLE and antiphospholipid syndrome is in like a similar kind of disease. Okay, I mean to say autoimmune disease, and also I think it is also present in livedo reticularis. Amantadine, pan, atheroembolic disease, SLE, and there are many things where livedo reticularis can be found, but I think these are some major scenario with livedo reticular. It is basically, um, if you'll see in image, it looks like marbling of the skin. Okay, it is just like marbling of the skin uh, on the skin lesion. Okay, so this was all that you need to know in respiratory unit. Thank you very much for watching.